You remember yesterday afternoon we broke up into small groups, 4 small groups, and we're going to hear reports back now. I'd like to introduce Dr. Polly Bednash, who will moderate the next session, where we'll hear from our 4 small groups. Thank you again for arriving so early this morning and welcoming our international colleagues and asking great questions.
So are we going to bring the other, the 4 folks up here? Okay. Come on up. Wow, what a fabulous start to the morning, and what an exciting series of discussions, and lots of work to come. I hope we can do something about a taxonomy. We have a lot of conversations about how we communicate with each other and what we do to try and share the information that we're working on. I do want to also say that I think yesterday's start with Sam Thier was the most spectacular setup for what we've been discussing over this day. And it was also a bit of a roadmap about where we should go and looking at the issues and what we do around mission and values and finding those right places and bringing people together. So this morning we're going to do a little bit of speed dating here. We sent 4 groups off yesterday to do some deep dive work around some of those issues that Sam Thier laid out, and we asked them to go with and work with a group of people. And I'm sure you all know that there are no shrinking violets in this group. So the groups that were put together, I think each of these individuals who were leading the groups had a strong challenge to try and take, I know the one group I was in, the multiple comments that were made and to distill them into 5 PowerPoints, and I think our group only decided to do 3, right, Hugh? We decided we're just going to do 3. 4. Oh, we got 4, Melissa. Okay, all right. And we had a debate about how you, and Hugh told us you can't put more on a PowerPoint than you can put on a T-shirt. So we were trying real hard to make them distinct and very clear about what we were doing. But the objective of this program was to identify, to further outline the dimensions of successful relationships between education and practice across the interprofessional education continuum. And that is what Sam Thier was challenging us to think about yesterday. So we're going to have 4 presentations. We have 30 minutes. We want to give you a chance to talk with the individuals briefly between each presentation. And we're going to start first with Warren Newton, who's going to talk about the local, institutional, and national factors driving the initiation of collaborative partnerships between interprofessional education and practice. Warren, you're on.
Great, thank you very much. It's an honor and a challenge to run this group. I'd say that the discussion was robust, and I'd submit the VERMA metric of robustness, which is we had only 2 people who had less than 2 comments over the course of an hour. Our focus was on initiation of partnerships, and I wanted us to keep in mind the diffusion of innovations. And I'll leave you to decide where IPE is on the diffusion of innovations, from innovators up to early majority. But I think we all understand that the motivations for initiation are very much dependent on where you are in the curve. Turning to what are the key drivers? I think all of us know that public demand, be it patients or employers or insurance companies or now the government, for improved value in healthcare. Clearly, influential reports like the IOM nursing study, the Lancet Commission play a role, as do the willingness to put money where their mouth is in the Macy Foundation and other foundations. And over the last 6 years, in the States as well as elsewhere, there's been significant movement by the payers, the government as well as the commercial insurers, to change clinical care dramatically. And what that's meant is that the deliverers of care are looking for benefits in quality and safety and in the cost of care, and they also recognize that their current workforce is unprepared for this goal. So the opportunity for academic organizations and their partners are to add value to care, to train and keep the right workforce, to develop the new partnerships they're going to need to survive, and to engage and attract the best students. So what does it take to put together an IPE-IPP collaboration? I think first, there are, and not all of these are required, but a formal process to sit down and jointly vision goals, what the gaps are, and take shared responsibility. The example of what the state of Minnesota has done and University of Minnesota is a wonderful example of that. Leadership, and a leadership that is distinctive and that it is collaborative and that, in the words of our Chinese colleague, is not abstract, so that it includes vision, it includes communication that is relentless, and it includes financing. But it's not just a function of leadership, it's also bottom up. It's the faculty champions that need to do that, along with the academic incentives to move forward, and student engagement to shape the initiatives as they move forward. And finally, the organizational infrastructure, the logistics, the staffing, and also funding. What are the challenges? And mind you, this is only one slide. It could have been others, but we're all here because we recognize the professional silos. And the concretization of those silos are the calendars, the poor space, the perceived lack of time necessary to do this work, as well as the need for new models of education. Beyond our professions, however, there are the institutional structures that are a challenge. Which disciplines do we have at the table? There are clearly many disciplines that aren't on the traditional health affairs campus that aren't at the table. Again, funds, startup and both startup and sustaining are important, as well as the academic rewards, the promotion and tenure. And I think we all recognize that there are partners outside of universities, in communities and employers, that we universities, speaking as somebody who's in a university, need to reach out to. And as we reflected on that, we kind of acknowledged, if you will, a series of culture chasms between and among our professions, between education and practice, and between traditional universities and new partners they will need to have. And of course, I think we all appreciate the lead anchor of accreditation, licensure, and payment rules. So what are the business case, what's the business case for doing this? And I think it's the triple aim. We know we need to improve patient experience, quality of care, and cost effectiveness, and it's across the continuum. It's from health promotion and disease prevention to chronic disease to transitions and cancer care and the like. The second case is also recognizing the expense of recruiting and retaining the workforce that integrated healthcare systems need. This is costly, we don't know how to do it, and this is a way to get there. And the third is, and this is a US example, there are dramatic changes afoot in the way medical education is financed, and it's an opportunity to take advantage of and align with those changes moving forward. So.
Thank you. I think we'll move through all four of the presentations and then see what we have left for time. So our second presenter is Donna Meyer, and she's going to talk about what makes collaboration between education and practice for IPE successful and sustainable. All right.
Good morning. It's a pleasure to be here to present from Group 2. Again, it was a real challenge as the facilitator because of all the information that was presented. I think I had like 15 pages and trying to get it down to present. It was also interesting just listening this morning to the first presentation, as there's so much overlap. Some of the things that we'd said, you will also find. So our first thing was the driving factors and elements needed for sustaining IPE. We came up with, first of all, vision and leadership. You have to have the vision for this, and you have to have the leadership. Strong communication of shared values, how you all feel about this partnership between both practice and education is essential to move this forward. You also have to have a strong strength of value proposition with this particular initiative. The workforce is extremely important. This was already mentioned, but the workforce not only from the university level, but also from the, somewhat the bottom up. We have to work on that and collaborate to make sure that we have the workforce that can actually initiate this project. Obviously, we also want to think about safety as far as patient outcomes, health outcomes, Quality. Obviously, that's what we're all here to talk about. The quality of patient care as well as population health is so very important. Cost. Obviously, there is some, concern about, is this going to be cost effective? How costly is this going to be to initiate all of these particular IPE collaboratives? Focus on population health. I, previously mentioned that. But because of the way healthcare is changing and the initiative for population health, this cannot be ignored. This group that we came together, it kept coming up again and again, population health. And again, finally, patient satisfaction. We all are in the business of making sure our patients are happy and that they have the best care possible. So we want to make sure in this initiative that they are getting that satisfaction that they so much deserve and are demanding of all of us. Evidence-based research. Obviously, we want this to be evidence-based, and we have to continue to do the research. We are so young in this whole project, and there's so much research that's going on, but yet it has to be actually completed. It has to be published. This is very, very important. We felt this was a really strong part to make sure that this is published and that we are a competency-based model for this initiative. Additionally, this is continuing the same redistribution of resources and savings. Again, going back to, is this going to be a savings? How expensive is this particular initiative going to be? Recruitment and retention of workforce. Does having an IPE initiative help? We kind of heard this morning that people are very excited. The healthcare workers for all the professions are excited about this. But will this actually help in recruiting and retaining both students as well as health professionals? Students are really the change agents here. From what we heard yesterday, our group really felt that the students are so very important. They're the ones who are probably going to push this forward more than some of the health professionals that have been out there. It's the students that are going to really be important. And integration of this particular initiative, the IPE, with curriculum and practice settings. You can't have just one, obviously. It has to be both the curriculum and the practice settings working together to move this forward. And as I already mentioned, the dissemination of the IPE values and best practices. Scholarship, publication, making sure this is published so that we can see what the best patient health outcomes are in this initiative. Challenges. Again, it's already been mentioned, somewhat funding. Is it more expensive to have this kind of initiative? Do you need initial funding to get this started? And reimbursement. How is this reimbursement going to work as far as when you have the different types of health professions working together? Also, right now a lot of our payment system is based on number of encounters. And this is going to have to be changed and looked at somewhat. Lack of leadership, lack of recognition of this need to change. That is a huge challenge. Again, as I mentioned, the beginning, we have to have the leadership to see this value going forward. So that can also be a challenge. Startup time for faculty. Obviously, when you start this initiative, our group really felt that there's going to be a certain amount of time that has to be in this initiative, and also joint faculty appointments. That's another thing that, will faculty be willing to work on this, and the fact that you do have to have some joint faculty appointments, faculty practice arrangements. And then this change in culture. That's been mentioned throughout here as far as, just a new thought process. Again, the business case. Need to build evidence to make sure we can show the value of the IPE. Increase coordinated care, better health outcomes, less adverse effects for our patients, improve processes, and the real need to continue to complete pilot projects and again, have these actually researched and then published. So our final is that we came up with, and I have to, that we really feel strongly to develop a discussion paper on principles and characteristics to address successes and sustainability of IPE, share our best practices, build on assessment and evaluation. And I have to quote one of our members, I think maybe this quote was borrowed, but Malcolm said, just do it. And the Imagine Clinic is an example from Canada, so we really feel that we just need to move forward here. We've got a great start, but we need to continue and just do this project. Thank you.
That's fabulous. So we're all going to take the Nike challenge right here, and we're going to just do it. Okay, Eric Holmbo will now talk about how outcomes of IPE can be measured and assessed, and assuming the ultimate goal is better health quality and improved value for patients and individuals
Thanks.
and communities.
Great. Well, again, also thank you for having me. I was struck by Group 2 talking about the need for a competency-based model, and Group 3 talking about the need to build the evidence base. So this is what this group tried to struggle with yesterday. It was a very rich conversation. I'm only going to scratch the surface of it as the others as well. This is kind of the overarching theme with regard to measurement assessment practices. If we're really being honest, we don't really know for sure what the best measurement and assessment processes are. This is really a work in progress. And this is pretty much true, by the way, for all of work-based or performance-based assessment. It's a relatively new field, if you will. It's been around about 25, 30 years and is getting more robust, but I think the measurement for IP very much falls into that. So the other thing that came up from the group I thought was very nicely said by a number of folks is we don't really know quite for sure what we should be measuring yet. You know, there's still some definitional issues which challenge the ability for us to measure. Certainly the clarity of purpose and analysis is a very important aspect of measurement. So what's the purpose of the measurement really should drive the type of measurement and the tools that you use. And we need common operational definitions and some common standards around those measures. As somebody pointed out, it'd be really nice if we had some signal measures that we could all agree on that would allow us for some comparative analysis. The other thing that was a really common theme, and I think it's very much highlighted by the Frank and the Lancer report and others, is you start with practice that produce high quality outcomes and you work back. We tend to work forward. Think I've got the student in front of me and I project forward instead of like, listen, what's the world they're going to need to enter, and then work back. And I love this quote by Larry Green, is we're really preparing physicians for a practice that currently does not exist. And that's really challenging. And that's happening, but that's a real challenge. So we have to really envision what we think the future practice should look like. And I think Stefanis's framework that he shared with us, which has been around, is a really nice one to help us with that. We certainly need to define the competency in more behavioral terms, but also with more specificity. I think that's been a challenge. It is across all of medical education right now. IP is not alone. One common principle in all assessments, you can't do this with one tool. There is no magic bullet, holy grail. This usually takes a combination of approaches and tools to do well, and that includes both qualitative as well as quantitative types of tools. And we've tended over the last century to really focus on the quantitative tools and really haven't been quite as good at using words. But words and narrative and things of that type can be very valuable. With regards to the goals, again, just reinforcing what's been a common theme, the ultimate goal is to improve health. That's really what we're at. And again, we heard a nice framework this morning. And we thought a lot about Dr. Thier's question about what's the value of IP and how do you define success. And we think that's actually a very prescient question that we need to really grapple with. Again, as I mentioned, what's the unit of analysis and where should we start? And there were some differences of opinion. Do we really focus on helping assessment at the individual level? Is it about the programs, about the institution, and where is the right balance to start? The other thing we talked a lot about is, again, this gets back to purpose. Are we really trying to develop assessment for the purpose of driving improvement or assurance? What Glenn Regehr calls kind of quality control. So we're okay, we feel comfortable this person has enough of something, so it's kind of a quality control. Is this really about driving improvement? And very much aligned with that, is this more about formative or summative type assessment? And if it's really more about improvement and feedback, then we really want to build tools that have catalytic effects. Nice body of work looking at what's called the utility of an assessment tool. One of the pieces of utility should be catalytic effect, which drives future learning forward. So instead of assessment of learning, we really want to have assessment tools that drive future learning forward. Resources, I think, again, the theme here is time. I mean, again, like anything, you need to spend some effort and time in order to do this well. Certainly, we need to bring in developmental expertise, methodology, and program evaluation, particularly given that there are a number of research strategies evolving around the world that really embrace complexity as part of the measurement strategy. And I think those can be very useful. And a couple were mentioned was realist evaluation strategy by Ray Paulson and Nick Tilley, Michael Quinn-Patton's developmental evaluation. There are other frameworks, but we're going to need to embrace complexity as part of the measurement process. We've tended to want to be reductionistic because it's easier to do that. You break something apart, you measure something really small. but sometimes you basically lose the meaning and the value when you do that. So complexity is going to have to be part of this. The other conversation was very interesting is, we always talk about assessment as something we do to somebody, right? It's something that I'm going to assess you. I'm going to do this to you. And we probably need to reframe that, is assessment is something should become increasingly self-directed. Again, this kind of even rigueur concept of self-directed assessment seeking behavior on the part of all health professionals, right? That's something we all need to do in order to remain good within our craft. So that's an interesting concept to think about. What does that mean for interprofessional assessment? What would that look like if somebody are being very self-directed and kind of measuring themselves? Certainly we need to embrace technology. There are a lot of things out there now that could already be helpful. We heard about portfolios already yesterday from Jan. It's actually a very useful strategy and tool. I actually think about portfolios as a verb, not a noun. Portfolio is a very active process and requires engagement on the part of the learner. So it really leads into that self-directed assessment seeking activity. Apps, there's a lot of stuff you can put on an iPhone, iPad, iBox, whatever, mini iPad now, that actually can work very well. Blogs actually can be a source of evaluation information. There are people using blogs within portfolios that capture what happens over time, particularly from a developmental perspective. And so that may be very valuable. And then obviously you can build some stuff into HIT systems. The other thing we talked about is you really need competent faculty. And this right now is a general problem for all of competency-based medical education, is that we have a faculty workforce across all the health professions that weren't trained in the very system we're trying to create. And so they're struggling. And so a lot of co-learning activities around assessment as well as education are going to be required. And it's probably the Achilles heel of an outcomes-based educational approach is really the faculty development. Challenges. This theme keeps coming up. It's time. And we didn't really get a lot of specificity here, but I've already mentioned faculty, the lack of kind of common standards for assessment, particularly in the kind of work-based environment. It's messy, and we're going to need to work with that. One of the things that I think is beginning to change, but I think needs to be accelerated, is we need more interinstitutional collaboration. And that's a theme I've heard over the last 2 days, and I completely agree with that. I think certain parts of the world are doing it better than others. I personally do not see that as a strength within medicine within the U.S., particularly in assessment. We have a lot of single institution studies that would really benefit from more interinstitutional collaboration. Funding is always a challenge, how to distribute limited resources, but that's always going to be the case. I think we're going to have to figure out how best to work with, constrained resources. And then finally, which we already talked about, there's good work underway, but right now we don't really have a good set of or suite of assessment tools, and we're going to need to kind of work those. We did hear some exciting work, however, yesterday within the group, so very reassuring that that work is going on, and I think it's going to be important to figure out how to share it. So we didn't get to business case, so we'll leave it to the other two groups. But thank you.
So this is our final report back, and it's around how you get buy-in from leadership and what is required to initiate and sustain that kind of support from the leadership. Hugh?
Yeah, good. Our T-shirt turned into a nightshirt. We needed a little bit more space, and Melissa and I struck a bargain. I think she drew the short straw, having prepared a wonderful note for us. She's going to lead us through, but Matty and I, who had some influence on the drafting, may chip in.
Yes.
All right, so on whom do we depend to provide leadership in key bodies to ensure their support for IP? So first we have to identify who are the leaders, who are the stakeholders, who are the key holders, and what is their relationship to each other, and what is their domain of power, and how this all fits together. And this is what we discussed extensively about, is this is relevant to the country, the region that you're located in, practice versus institution, community versus academia, etc. There's also multiple levels of leading. So there's formal leaders and there's informal leaders. And everyone needs to learn to be change agents. And whether you're in the student sector or the international or government and policy, We have to recognize that there's just not one leader. And also, leaders are not them, they're us, and they may be your teammates, to use the team words. And really, it's about relationships. What is your relationship to these leaders? What are the relationship of the leaders to each other, like we were talking about a few seconds ago, and the institutions working together, and really about building trust over time. So what briefing, information, advice, encouragement do they need from us, they meaning the leaders? We need to have clear, consistent messaging and definitions. Leaders need evidence, continuous communication. Again, I'm repeating a lot of what's already been said. Feedbacks, updates, and to recognize that there are different types of evidence. There's the initiating group of evidence. You have to define that problem really well. And there's the sustaining evidence, and you have to continuously show that difference. And again, evidence has different meaning to different recipients. We need to know who we are speaking with and really understand the currency of what they need, their particular return on investment, or ROI. Language of the conversation really matters, as we've heard over the last few days, or the last day. And there is a right place at a right time kind of importance here. There's a flashpoint, there's a critical mass of the amount of evidence that we build, how visible we become. What is the economy of scale? So from a leadership standpoint, are you helping me with what I need to accomplish in my particular position as an administrator, leader, fill in the blank? There are examples of this, of how it really works well, and that includes the how, when, why, and the context. And it's not just about convincing, again, it's about that connection and relationship building, and to get the students, the consumers, to demand and push. So students and patients need to be in this equation. And they are potential leaders too, and we have to recognize that and develop and foster that. So what do we expect back from the leaders? We want to see them have key characteristics. We want them to be permissive, encouraging, directive, explicit. We obviously want them to deliver resources. We want them to model and enforce accountability, which includes promoting and sustaining a culture of teamwork and respect. And finally, what tools and capacities do we need to champion and explain IP to leaders? Well, some of the tools that we need have already been said, but there are examples, again, of these institutions globally that can demonstrate the power of IPE that needs to get out there, right? We need scholarship, publications, PR of the current outcomes. And capacities, like I mentioned, leadership training, interprofessional and collaborative, that the Canadian collaborative is so well leading, and the collaborative collaboratives, leadership development of the youth, the students, patients, younger faculty, current practitioners. Ideas for how to sustain this, to be able to show the difference, is really important, so that the assessment and measurement becomes really important, so that we can move more effective, fluent at convincing leadership the importance of IPE.
Melissa, thank you. I think that was fantastic, and I'm not sure that we want to add anything, do we, Matty, given the limited amount of time at our disposal?
I just made a couple of points from our discussion. We talked a fair amount about marketing related to getting the message out there, and that we don't do that very well, and that we can use marketing colleagues, public relations folks to help us tell the stories and get the message out. And then I think the other part we talked about, which was on your slide, Melissa, that we slid over, was that it's not only that formal sort of presentation, it's also the network of influence and the informal ways that we get the message to the people who need to hear it.
Thank you. You talked, Minister, about the different levels, and of course we did. I think we were also thinking, in my mind, in concentric circles. And a lot of the discussion naturally focused around how it was for ourselves, or some of the group, not perhaps me, as leaders in relating to others who were leaders in other situations within the institution, within the partner organizations, outwards and outwards and outwards. Hugely complicated, but thank you for summarizing it for us.
You did a great job. Very good. Very good. Well, I feel so relieved, because now I know exactly what we need to do, right? This really was a huge array of ideas and factors that we need to address if we really want to make this real. It'll be important, I think, for us to take the results of these 4 groups and try to compile them into some composite array of factors and items. There was a lot of overlap there and redundancy, which is also heartening because it says we're all moving in some similar directions here. We have huge challenges ahead of us, all of us. We did start a little bit, we started about 10 minutes late, and we could probably do about 5 minutes, 3 minutes, Lucinda says. That's okay, we got to keep on. So is there anyone who wants to make a comment? Marla.
I think this is fantastic, and the question that came up in my mind is, who do we need to talk to that isn't here that is hard, is a particularly challenging audience? Mm-hmm. And it seems to me that there's a partnership, there's a financing opportunity, and there's a support opportunity in the broader higher education community. We're not the first to do interprofessional. And there are some problems that we in health sciences present to that community that this could be an answer for. So I think, what do university presidents, chancellors, et cetera, boards think about health sciences, and what kinds of problems are they for them? And I think that we're substantial in some ways. And I think the other group that is important are the educational funders. And this is from the research perspective. And funding I saw many times coming up, but I didn't see funding from whom for what. And educational research is phenomenally underfunded in the health sciences, not so much in some other areas. So what's the case we make to higher educational funders wherever we may be? And I will cite the Carnegie Foundation report on nursing, which was fantastic. Where's the broader funding? So that's it.
Well, several of us talked about this yesterday too. That some other players that are not here are perhaps the payers. If in fact it's in their interest to have interprofessional practice and the potential for better outcomes with that, maybe the payers should be here, and maybe some of the large system folks besides the VA. We have the VA here and some others being here, so that's important. I want to make sure we get to both sides of the room. Pat. George?
Well, first of all, I want to compliment them for making a chaotic discussion into a rational one. Or I said, and not only one of them, and Warren did a masterful job, and I suspect it was duplicated by the others. I want to just call attention to something underlying all of these, and that is that we need to become much more expert in culture change. And there is a literature about it. Mm-hmm. It is not exactly what each of us has been trained to do, mm-hmm. but and I think there's 2 different kinds of culture change we're involved in, and though they do reinforce each other, they are different. One is the culture change that we've talked about a lot, of breaking down the silos profession to profession, moving from hierarchical thinking to more collaborative thinking. Mm-hmm. But then there is a profound culture change between the academic world and the practice world that we've probably not paid enough attention to, of what the different incentives, drivers, and reward systems are in the 2 worlds. And I think we probably need to spend a lot more attention, not only thinking about that, but learning about that, and learning the skills and tools to be, in a mindful, conscious way, culture change agents. And it underlay all of the discussions, but I think we need to be more explicit about that. That mm-hmm. unless we do that, we're going to continue to come up against major obstacles.
Thank you, George.
Beautiful segue, because right after we take our break, we're going to really begin to examine some exemplars in bridging that academic practice mm-hmm. partnership gulf. I'm going to recommend that we take our full 20-minute break right now. We're going to subsume the stretch break later. So please come back at 10 o'clock to start the next segment, and thank the panel.